this will be the last section in the pulmonary chapter, and I will be doing case 8 and 9 over this time, and I will leave case 10 out as a bonus case. This is the last case. The case 10 is a case of a malignant pleural effusion. I would suggest for people to look at that case, but I'm going to leave it out of our talk now. So over to case 8. We have a 65-year-old man who comes to the clinic for the evaluation of dyspnea on exertion for several months. He also complains of cough, which is generally dry. He denies fevers, chills, chest pain, and weight loss. He's a retired bank teller who never smoked. He has no pets and no recent travel history. There is no significant past medical history in this patient. His temperature is 98. His blood pressure is 120/80. The pulse is 100 and respiratory rate 24. He is well developed, overweight, and in no acute distress. The physical examination shows an augmented P2 and Velcro rails at the lung bases bilaterally. Examination of the extremities shows clubbing. The remainder of the physical examination is unremarkable. So really, this patient with a shortness of breath, and that has been going on for some times, for several months, clubbing and an augmented pulmonic sound lets you think of definitely of pulmonary diseases that would do that. And of course, there's a lot of pulmonary diseases that could do that. Any of the interstitial lung diseases, sometimes chronic obstructive lung disease could do that. But definitely the first things you think about is the interstitial lung diseases. Interstitial lung disease is a wide range of heterogeneous types of diseases that affect the lung parenchyma. They are restrictive diseases, so when you look at the pulmonary function test, the total lung capacity residual volume will be decreased, so restriction. And they usually present, the more common presentation is shortness of breath, usually dyspnea on exertion. They occur over months, sometimes over years. This is usually not an acute presentation. On the exam, you rarely find any evidence of heart failure. Sometimes they do affect the right side of the heart, but there's no other evidence of heart failure. So congestive heart failure is a possibility if you find evidence of jugular venous distension, of displaced apical impulse that we didn't find in this patient. Ischemic heart disease, somebody sometimes presents with dyspnea on exertion and should be thought of. They usually have chest pain more rather than dyspnea on exertion. And idiopathic pulmonary hypertension is sometimes a scenario where we see dyspnea on exertion. They usually occur in women about 40 to 50 years of age, but they do present with dyspnea on exertion. There are no lung findings, though, and usually there's no clubbing on the exam. Chronic obstructive lung disease and emphysema, whether it's chronic bronchitis or emphysema, sometimes will present with dyspnea on exertion. We should see evidence of the AP diameter increased. We should likely have a history of smoking, productive cough. The X-ray will show evidence of the flattened diaphragmatic surfaces and the hyperinflated lungs. On the pulmonary function test, this will be very helpful to diagnose the difference between this and a restrictive process like interstitial lung disease, because on the pulmonary function test here, you're going to show evidence, you're going to see evidence of obstruction rather than evidence of restriction. Sarcoidosis, we talked about a case before where we had a young woman that presented with cough. And sometimes it presents this way with shortness of breath, but it's usually at in a younger population. And sometimes exercise-induced asthma, this patient's a little bit too old for that. So we will think less likely of it. So the initial diagnostic plan in this case, given the findings of clubbing, the Velcro rails at the bases, the best test to do initially is the chest X-ray. The chest X-ray will guide what you do after all this. So in this case, you find bibasilar interstitial infiltrates with peripheral honeycombing. This could occur in any of the 300, 350 different types of interstitial lung disease. Now, we said that the interstitial lung diseases are different diseases, anywhere from the pneumoconiosis, these occupational lung diseases, to some other diseases like idiopathic pulmonary fibrosis. They all present the same way. they present with dyspnea on exertion, have the same X-ray findings, which are interstitial infiltrates and sometimes honeycombing, and they all have abnormal pulmonary function tests consistent with a restrictive pattern. Because they affect the alveolar membrane, they will have a restrictive pattern plus a DLCO that's decreased. So all the interstitial lung diseases will have pulmonary function tests that are consistent with this. Total lung capacity will be decreased. Residual volume will be decreased. You could remember that in obstructive diseases like asthma and chronic obstructive lung disease, total lung capacity and residual volume were normal or increased because of the hyperinflated lungs and the flattened diaphragmatic surfaces. The FEV1 over FVC and the FEF 2575 will be normal. This is not an obstructive disease. And the DLCO, in this case, will be decreased because you have the alveolar membrane destroyed. So a couple of the other things that we saw in this case is they did the pulmonary function test, and here you go on number 4. As a result, we have decreased lung volumes with an increased FEV1 over FVC. Sometimes that ratio could be increased or normal, and decreased DLCO, decreased oximetry, rest, and exercise, so they have hypoxemia. And of course, if you look at the echocardiogram and the electrocardiogram, you really don't find any evidence of ischemic heart disease, of congestive heart failure, but you do find that this patient has a left ventricular ejection fraction that's normal and a normal heart size, but you find an elevated pulmonary artery pressure, and this is because the pulmonary hypertension transmits pressures to the right side of the heart. In fact, one of the ways that people with interstitial lung diseases have morbidity and mortality is through cor pulmonale, right-sided heart failure. If you look at the echocardiogram, you find sinus tachycardia with evidence of right ventricular hypertrophy. Again, this is because pulmonary hypertension and transmission of pulmonary pressures to the right side of the heart and cor pulmonale. So when we said the initial test would be an X-ray, a chest X-ray in a patient like this is the first test to do. The second test to do is probably a pulmonary function test that would tell you this is a restrictive pattern. A couple of things that are going to help in this patient is an occupational history. A lot of the occupational lung diseases like silicosis and asbestosis cause interstitial lung disease. So the occupational exposures here are very important. If you find this, the third step, so here we go, in a stepwise fashion, the third step to do here is get a transbronchial biopsy to find out what the cause is in this patient. So out of the 350 diseases, you may have some clues from the clinical examination or the exposure, but what it really comes down to, once you have a restrictive disease that is intrapulmonary, by definition, you're talking about an interstitial lung disease. The next step to do here is a transbronchial biopsy to make a definitive diagnosis. There's a lot of possibilities here. So the way you diagnose it is through the biopsy. Now this patient, we did that, and you find areas of moderate fibrosis with minimal evidence of active alveolitis. Now, this is consistent with this disease called idiopathic pulmonary fibrosis, that you find non-specific inflammation and fibrotic changes. You really ruled out everything else here. You ruled out pneumoconiosis, co-workers pneumoconiosis, because you didn't find anything. You didn't find anything consistent with silicosis and a lot of other things. So this is usually a diagnosis made through not finding anything else on the biopsy. Now, people with idiopathic pulmonary fibrosis, the name says it. It's idiopathic. We don't know why it occurs. It usually occurs in men, usually in their 5th or 6th decade of life. There is fibrosis of the lung. It occurs over a long period of time. And eventually, these people develop either lung failure or, more commonly, cor pulmonale and right-sided heart failure from the pulmonary hypertension. The treatment, although not good in this case, is steroids. The steroids are only effective in a small percent of the population. Maybe about 30-40% of the cases in some studies, maybe even a little bit less. So you give the patient steroids. If they improve, then good. You keep them on the steroids. If they don't improve, what some people suggest, using things like azathioprine and cyclophosphamide with the steroids or without. The bottom line here is that most of these diseases usually progress unless you do some definitive treatment, which is lung transplantation. So that's idiopathic pulmonary fibrosis. I want to recap on this and say that idiopathic pulmonary fibrosis, from the case review notes, they usually affect people about 50 to 60 years of age. They have dyspnea on exertion and minimal cough. This is a presentation of interstitial lung disease. They have fine crackles throughout the lungs and no evidence of any congestive heart failure or anything else that would point to other diseases. The arterial blood gases have hypoxemia and respiratory alkalosis because these people breathe fast. And the chest x-ray shows the interstitial densities that we saw in the honeycombing and the pulmonary function test show a restrictive pattern with a low DLCO. This is not different from any of the other interstitial lung diseases. So in your case review here, please use this to think of any of the interstitial lung diseases this way. They have the same findings and they present the same way. So really, what's going to give you the right diagnosis here? You will always have to come down to a transbronchial biopsy to make a definitive diagnosis, because all these diseases present the same way. They have the same patterns on the pulmonary function test and the chest x-ray. Sometimes there's small differences, and we'll talk about them, but they usually present the same way clinically, pulmonary function test-wise, and chest x-ray-wise. So you got to know that. Idiopathic pulmonary fibrosis put the same as any other interstitial lung diseases. Okay? Very good. So going a little bit further down, I wanted to before we get to case 9 and talk about another type of interstitial lung disease, I wanted to go back here and make sure you understand one last thing about pulmonary function tests. Now, all this time, we've been doing the pulmonary function test as a diagnostic test, right? We did it in obstructive lung diseases. It told us the difference between asthma, right, and chronic obstructive lung disease, because asthma is reversible, the other ones weren't. It told us the difference between chronic bronchitis and emphysema, because emphysema affects the alveolar membrane and chronic bronchitis doesn't. And it told us the difference between a restrictive pattern and an obstructive pattern. So we used it diagnostically. Take a patient with idiopathic pulmonary fibrosis. You put them on steroids. They may feel a little bit better. Most people that are given steroids initially feel better. How can you document this objectively? Here you go. You take the patient again 6 months later or 4 months later or 3 months later. You do the pulmonary function test. If the steroids have worked in this patient, then you will see that the total lung capacity has gotten better, the residual volume has gotten better, and so forth. The DLCO has almost normalized. So they're also used to track response to treatment. So we use the pulmonary function test diagnostically. We use them to see the effect of medication in the progression of disease. And 3, it also gives us an assessment, a prognosis on some diseases. I told you that in chronic obstructive lung disease, if I know the FEV1, I could tell you how bad this disease is in these patients. So, diagnosis, prognosis, effect of treatment, and the use of pulmonary function tests before surgery to see if you're going to take out a part of the lung, if you have viable lung left in order to do the surgery. So they're not only used as diagnosis. The last thing I want to say here before we move on to case 9 is this. If I gave you a patient that has a restrictive pattern with a normal DLCO, right there, this is the most common pattern that you see in pulmonary function testing. An abnormal restriction, a restrictive pattern with a normal DLCO. The most common reason this occurs, and this is the most common abnormality we see out of everything, is in extrapulmonary restriction. Extrapulmonary restriction occurs in people that have severe kyphoscoliosis. They have morbid obesity. And sometimes in people that have neuromuscular disease, like myasthenia gravis, MS, Guillain-Barré, and so forth. So look at this. I'm giving you a restrictive pattern, but the DLCO is normal, which means that the alveolar membrane is not affected like we would be talking about interstitial lung diseases. So in this case, the choice is always to look for extrapulmonary restriction. It's very common for this pattern to occur in older individuals with severe kyphoscoliosis. That's the most common pattern, the most common abnormality that we see in pulmonary function testing, extrapulmonary restriction. Okay? Very good. So going on to case 9, now we have a 66-year-old retired construction worker who now comes to the office for evaluation of shortness of breath. It sounds like our previous case. So this guy is having shortness of breath over some time, over the past 5 months. In association with this, he describes a dry, non-productive cough, which began about a month before the onset of shortness of breath. He has been in excellent physical condition, walking about 2 miles a day for many years. Recently, however, he has been able to walk 3 blocks without stopping to rest. So it sounds like the previous case, dyspnea on exertion. This could be a heart disease, but this could also be a lung disease, restrictive lung disease. We talked about an interstitial lung disease present exactly the same way. He has been in excellent physical condition, walking 2 miles daily for many years. Recently, however, he has been able to walk 3 blocks without stopping to rest. He is a former smoker of 2 packs per day for 20 years. He quit 3 months ago because of his difficulty breathing. So this has been going on for some time. He is well developed, well nourished, and no acute distress. His temperature is 36.7, blood pressure 140/85, and his pulse is 86, and respiratory rate is 22. Physical examination shows bibasilar coarse crackles on the chest, auscultation, but is otherwise clear. Examination of the extremity shows clubbing. So this has been going on for some time. This is a lung disease likely. The remainder of the physical examination is unremarkable. So, of course, without any jugular venous distension, without any apical impulse displaced, you definitely think about interstitial lung disease. Any of the interstitial lung diseases you definitely should think of, and idiopathic pulmonary fibrosis like we did before. Here, they also thought of asbestosis and the occupational lung diseases because this guy was a construction worker, so it's fair to definitely think about that very high on your list. Bronchoalveolar carcinoma does this sometimes. It really doesn't present usually with shortness of breath, dyspnea, and exertion unless it causes an effusion in the lung. They usually present with either hemoptysis or some obstructive pneumonia or something like that, usually not dyspnea and exertion. We talked about chronic obstructive lung disease and emphysema before, that sometimes progresses and it presents with shortness of breath. We should have seen more findings. AP diameter increased. These people should present with some cough a couple of months out of the year and so forth. And ischemic heart disease mostly presents with chest pain rather than dyspnea and exertion, but it's definitely something to think about in a 66-year-old man. So again, the first thing we do in this case is the chest x-ray. All patients that have evidence of lung disease, we should do the chest x-ray first. That's number one, like we did before. And in this case, again, we find that this patient has bibasilar interstitial evidence with honeycombing and pleural plaques. So the same x-ray that we saw before, but this person has something a little bit more. So here you go. We found bibasilar interstitial densities, so at the bases, and plus, this patient, we are told, has a pleural plaque. Now, that's significant for something. That doesn't occur in other interstitial lung diseases. Evidence of basilar disease, lower lung fields affected, plus the pleural plaques tell you that this is a good possibility for asbestosis. Pleural plaques occur over the pleura and sometimes over the diaphragmatic surfaces, and it is almost pathognomonic for asbestosis. So you definitely think about asbestos in this patient, especially with the prior history. And if you evaluate the rest of the stuff they got on this patient, the electrocardiogram shows right axis deviation, prominent P waves, but no ST changes. So that goes along with something in the lung affecting the right side of the heart. The pulmonary function test, remember that's the next thing we always do here to document that, should show a restrictive pattern with a decreased DLCO. And that's what you find. Decreased total lung capacity and residual volume with decreased DLCO, and in the echocardiogram, no evidence of congestive heart failure. So this patient has some kind of restrictive lung disease. Now, what did we say was the third thing we always consider doing in these patients, and that is a biopsy. Now, in this patient, you almost have the diagnosis. You go back into the history to see where this patient, where and if there was exposure in asbestos. Remember, in occupational diseases, especially occupational lung diseases, the history is the most important tool that the patient has. It is the most important thing. If there is no evidence of exposure, you can never think or look for the right diseases. So you have to know what exposures are associated with what diseases. We know that asbestos exposure is associated with people that did shipping, that worked in shipyards, did the painting in the shipyards, that did the car brakes in cars because the car brake lining was high in asbestos, and people that did insulation, construction workers, insulation, and so forth. So these are the three things that we think about asbestos. Silicosis, on the other hand, is another interstitial lung disease. Silicosis usually affects the upper lung fields. So it causes an interstitial pattern, usually affecting the upper lung fields. Silicosis are usually people that have worked with silica quartz. So sandblasters, coal miners, and so forth, granite workers and so forth. These are the people that get exposed to silicosis. This person was a person that was a retired construction worker, so you definitely think about asbestosis in this case. Now, if you come and biopsy this person, and you always have to do it, this is a must. Always in these diseases, even if you're pretty sure what the patient had, you have to do it for litigation purposes. That's one reason. The second reason is, so if there is exposure, you document the exposure and you go find it and stop the exposure in other people. So it's very important to document that this patient has asbestos. If you go back with just the x-ray to the company telling them this guy was exposed to asbestos and has interstitial lung disease because of that, they will tell you no. He's got interstitial lung disease and he's short of breath and stuff like that because of smoking. You got to document that. If you do a biopsy on this person, especially at the pleural plaques, this is what you will find. You'll find these little dumbbells, and this is the asbestos fiber. Now, what happens with occupational lung diseases? People inhale the asbestos particle or the silica particle or the coal that coal workers' pneumoconiosis get. It goes down to the alveoli, causes an inflammation, recruits macrophages, causes chronic inflammatory process. After chronic inflammation, what happens to the lungs? They get fibrosed and they get restricted, and then you have long time inflammation and fibrosis. It's like a vicious cycle. So you got to document the asbestos fiber. The treatment of this is really to stop the exposure. If the patient is being exposed still to these particles. So any occupational lung disease, the first thing is to make sure the patient doesn't get exposed and other people are not being exposed to this. The second thing, especially in asbestosis, is to stop smoking. Now, people that smoke and have asbestos exposure have over 75 times the risk of a normal patient to get bronchoalveolar carcinoma. I'll say this again. They have over 75 times the chance of a normal individual to get bronchoalveolar carcinoma. It is bronchoalveolar carcinoma that is most prominent, mostly seen, most common cancer seen with asbestos exposure. It's not mesothelioma. It is not mesothelioma. It's bronchogenic carcinoma. So this is the one you're really concerned about. And this is the one that is associated with smoking. Now, mesothelioma is a possibility in these patients. It's a rare cancer. It arises from the pleura. So when they show you an x-ray, you'll see that the mesothelioma extends beyond the lung parenchyma into the pleura. So here you go. It's kind of like a mass that extends to the pleura because it's a pleural mass. Most of these people present with effusions, bloody effusions. So if they tell you that this guy has pain and it's got an effusion and you take the fluid out of the effusion and there's all blood, maybe they're talking about mesothelioma. It is not nearly as common as bronchogenic carcinoma in people with asbestosis. It is not associated with smoking. Not associated with smoking. It's just associated with the asbestos exposure. So these people, the best thing that you could do is stop the exposure and stop smoking, and you can't do anything else. So this concludes all the cases in pulmonary. I'm going to stop right here. Again, I will not do the 10th case. It's a case of a malignant pleural effusion. I would highly suggest that you look at it. It is an important case. We will not get into that, so I'm going to stop right here.